I'm Dr. Ken Landau. Thanks for watching. Let's talk about floaters. Floaters are the sensation of dark spots floating in your visual fields. They're very common. Almost everyone's going to experience them. A lot of the reason people see their family doctors complaining about something wrong with their vision. Another problem is flashes. Flashes are photopsia, the perception of flashes of light in the absence of any light stimulus. Well, to understand these conditions, we have to learn a little bit about the anatomy of the eye. The eye is divided into two segments, the front part or the anterior part, and the back part, the posterior part. The front part has the fluid in it, that's the aqueous humor. The back part that extends from the back of the lens to the retina, it's filled up with a gelatinous material that we call the vitreous. Vitreous occupies about 80% of the interior of the eye. The volume is about 5 cc's, about a teaspoon. It has the consistency of jello or a fresh egg. The whole purpose of the vitreous is to occupy space. It allows the clear transmission of light from the outside to the retina. If we look at the vitreous itself, it's homogeneous or homogeneous. It's extracellular matrix, 98 or 99% water, a little bit of collagen, that's a structural protein, has a triple helix structure, like having 3 hairs twisted together, but obviously tiny. We have hyaluronic acid. That's a type of a material that the doctors inject into your skin to plump it up. The reason is it tends to hold water. The hyaluronic acid, or hyaluran, is a polysaccharide, a glycosaminoglycan. There's only a little bit of it present. So the average weight of a person would be about 70,000 grams. There are about 15 grams of hyaluronic acid in the eye. It's relatively acellular. There are some cells in the back portion of the vitreous. Those are the cells, the hyalocytes, that make the collagen, that make the hyaluronic acid. Now, normally, the vitreous is attached to the retina in a couple different places. In the back around the macula and the optic nerve, and in the front at the junction of the retina and the ciliary bodies. The ciliary bodies are what holds the lens in place, and they make the aqueous humor. Well, you can get some disruption of the back part, especially if you have some sort of trauma. And the trauma could be strenuous athletic activity. You could be engaged in football or hockey or soccer. You could have a fall, or you could have a motor vehicle accident. You could have routine eye surgery. But the most common reason for the separation of the back part of the eye, something we call posterior vitreal detachment, well, that happens to be you're just getting older. And as you get older, the water content leaves the eye, just pretty much the same way as it leaves the skin. You look at a baby's skin, it's nice and smooth. You look at a person's skin who's 60 or 80 years old, it tends to be more wrinkled. And that's what happens to the vitreous. It tends to get more wrinkled. It tends to lose some of the water content. And when it does that, it shrinks. And when it shrinks, it puts some traction on the junction of the vitreous and the retina, and the separation leads to the floaters. Now, in the back portion of the eye, there are those collagen fibers that I mentioned that are perpendicular to the retina, and they sort of hold the vitreous in place. In the front part of the eye, the attachment isn't nearly as strong. The collagen fibers run parallel to the surface of the retina, and the vitreous is held to the retina by the laminin and fibronectin and chondroitin, other kinds of substances. Well, at birth, the vitreous body is a colloidal gel. With aging, as I said, it loses some of the water. Now, the water is in a gel form, and we have several different things that are happening as we get older. So we separate the gel form from the water, so little tiny areas. And when we have the gel form separated from water, the water leaving the gel form and turning into the liquid form, then we get an interface. And light is going to bounce off that interface, and when the light hits that interface, that's a floater. And then additionally, we have the collagen that's bound to the hyaluran, or the hyaluronic acid. And when those two separate, it also allows the collagen fibers to join with other collagen fibers, and then they can accrue in mass. And when they accrue in mass, then when the light hits them, you get another floater. And then when we have the posterior detachment, we have a significant amount of activity that's occurring in the back part of the vitreous because of the collagen tissue. And that, again, allows us to have this particular problem with the floaters. Now, when the vitreous is free to move about because it's no longer tethered at the back, sometimes it bumps into the retina, and as it moves around, bumps into the retina, it causes flashes or the photopsia. That's a very common reason for developing. But as the vitreous finally pulls free, then the flashes tend to stop. Now, you can get secondary floaters, and secondary floaters can be caused by vitreous hemorrhage, or it can be caused by neovascularization from diabetes, and you have some bleeding into the back part of the eye, some trauma. You can have something known as asteroid hyalosis. That's where you can actually get some calcium and phosphate and fatty acids in the back part of the eye. Hydroxyapatite, we call it. And that tends to occur as we get older as well. You could have an inflammatory condition, an infectious condition, non-infectious condition. You could have a neoplastic condition, a lymphoma or melanoma. You could have an intraocular injury, maybe because of previous retinal surgery. Maybe they injected some silicone oil into the eye. Then you could have the remnant of that can cause some issues with floaters. You could have an injection of the material for acute macular degeneration, the age-related macular degeneration, and that sometimes has an air bubble left in it. That tends to disappear over a short period of time. So the cause of the floaters can be all of these things and more. Sometimes in third world countries can be due to parasites, or sometimes amyloidosis, sometimes an injection of cortisone into the eye. All of those can cause the problem. And floaters tend to be chronic, of course, and they tend to be progressive as we get older. Well, what are the floaters? How do you notice the floater? You see it as a mobile spot or a string or a strand, or sometimes a straight or a curved or a squiggly line or a black spot that's in your vision, or a blob or a C-shaped object, or sometimes you see it as a spider or an insect or a worm or a fly darting across your field of vision. Or if it happens to be right over the optic nerve head, maybe it's a cobweb. Maybe you see it as something that is more akin to dirt on a windshield. That's what floaters are. And the floaters seem to move around. There seem to be some intravitreal currents, and the floaters move with movement of the vitreous or with movement of the eye or the head. They tend to jiggle. If your eye moves to the right, the floaters are going to move to the right, and then they're going to recenter themselves. They can disrupt and they can scatter light. So you can see one floater, you can see hundreds. Typically you see them in both eyes, but you could see them only in one eye. Then we have to worry about some underlying eye condition. But typically, as a person gets older, one eye might predominate. But we have to worry about, well, does the person have some underlying cause, a peculiar situation? Is it the posterior retinal or posterior vitreal detachment in one eye, or is it a uveitis, or is it because of a retinal problem? Well, the lesions or the floaters tend to be relatively small, sometimes moderate size, but the size and the number have no correlation with the complaint. So some people have an awful lot of them and don't have any complaints. Some people have relatively few and have major complaints. Example would be that asteroid hyalosis, the hydroxyapatite, sort of the stuff you see in bone with the calcium and the phosphate and the fat. It occurs in about 1 to 2% of adults over age 55. Person has dozens to hundreds of these spots inside the eye, but they tend not to cause too much problem because they're perfectly round. And things that are round that don't have any sharp edges or don't have any irregular edges tend not to cause too much problem. It's those squiggly lines and the C-shaped objects that tend to cause the problem. And then we have issues where they're more noticeable outside or in bright lights. So outdoor activities, looking at a computer screen or looking through binoculars or microscopes. They can be especially annoying, especially to people who are truck drivers or people who are athletes and spend most of their time outdoors. Over a period of time, if the lesions are due to the typical causes that we mentioned, they have a tendency to grow. Now, unfortunately, when they're in the field of vision, and they have to be inside the field of vision, they can't be peripheral in order for you to notice them, but if they happen to be centrally in the central vision, then they can cause what we call light scattering or stray light. And that can cause halos and glows and hazy vision and difficulty driving at night, difficulty recognizing people's faces. And then we can have some contrast sensitivity. That casts a shadow. The light hits and you don't see anything right behind where the light is now pushed to the side, sort of like having an umbrella. So that can cause significant problem with the vision, significant impact on the quality of life. Primary floaters tend to be much more common in myopes, people who are nearsighted. They're about 3.5 times more common than in people who are farsighted, about 4.5 times more common in people who have normal vision. Well, maybe 75% of people are aware of floaters. Only a third of them are going to complain about them or notice them. There's the notion that you get used to them, or maybe they just settle down and they go to the bottom of the vitreous so they're not in the field of vision anymore. That's not true. If you have the new onset of a lot of floaters, then that's cause for concern. You probably ought to see the doctor, but you have to remember the posterior vitreal detachment is very common, going to occur in probably 2/3 of people by the time they're age 70. It's not going to affect the vision, not going to affect the visual fields. But if you have a sudden onset, then it might suggest that you have retinal detachment, and certainly if you've had recent trauma or recent intraocular surgery, or if you had a history of retinal detachment, or if you're a high myope, you're very nearsighted, those are all risk factors for significant issues that might mean that you ought to talk to the doctor. Now, flashes are completely different, but they're in the same family. So flashes tend to be benign and they're not worrisome. We talked about the impact of the vitreous moving and hitting the retina and causing some nerve signals. Well, that's a relatively common situation. Tends to be not painful. Immediate eye examination is not really necessarily warranted. And generally, people who have flashes happens to be binocular and not even caused by something wrong with the eye. Most of the people who complain about flashes, it's migraine headaches. It's the aura of the migraine headaches. You get these zigzag lines, the flashes. They tend to disappear relatively quickly. They come on shortly before the onset of a headache. They only last about 20 minutes to an hour, and then they go away. There is another condition, and it's called a retinal migraine. Now, a retinal migraine is not the same as the aura from the migraine. In the retinal migraine, you don't get any headache. You just get these zigzag lines, and you get the flashes that otherwise would seem to be an aura, but it's not followed by a headache. Additionally, we know that flashes can be caused by a variety of other really important kind of problems, from a low blood pressure, especially when you stand up. We call it postural hypotension. That tends to mean you don't have enough volume. Or it might be because you have syncope, you faint. Or it might be because you have a mini stroke or a transient ischemic attack in the back portion of the brain, the vertebral basilar area. It might be an occipital stroke. Could be from an intracranial injury or an occipital tumor in the back portion of the head. Could be from hallucinations. Now, originally, when you develop either the flashes or the floaters, you can't tell whether it's serious or whether it's not serious. Certainly, if you have long-standing condition and it doesn't seem to change all that much, then we don't have to worry about it too much. But if it's new onset, and if you have blurred vision or red eye, or if you have pain or tenderness or discharge from the eye, you have photophobia, you can't look in the bright light, or bright light seems to irritate you, or you have visual loss, well, then you ought to go and talk with the doctor, especially if you happen to have diabetes or diabetic retinopathy or on blood thinners. You've undergone some sort of a trauma, or you have a bleeding disorder, or you have previous eye disease. Well, once the eye doctor evaluates you, it's a relatively straightforward evaluation. Looks into the eye, checks your visual fields, does some ophthalmoscopy, looks into the eye with that little handheld thing, but that's really not adequate. What they have to do is they have to look in with a slit lamp, so that means you need to see an ophthalmologist or an optometrist. They check the vision, they check the vitreous, they see whether it's clear or not. They sometimes do ultrasound examinations. Ultrasound examinations can tell if there's vitreal detachment, if there are aggregates of collagen, can tell if you have that gel and the liquid interface. Now we have the quantitative ultrasound examination that can measure the severity of the problem. Now, it's a problem that begins when people are around 4 years of age, at least as far as the liquefaction is concerned. The problem seems to increase in frequency as we get older. So between ages 20 and 40, about 5% are going to have some gel-liquid interface. It's going to cause floaters. About 20% of the people in their 40s, about 60% of the people in their 50s, about 80% of the people over age 60. But not all floaters result in symptoms. They have to be in the visual axis. So they can't be peripheral. They can't be off to the side. The only ones you notice are the ones centrally. Now, the eye doctor can do some special tests if it's appropriate. Generally not. If there's a suggestion that you might have retinal detachment, maybe fluorescein angiography is appropriate. And then we come to treatment. What do we do about the problem? For the overwhelming majority of people, we just reassure you. We say there's nothing wrong with your eye. You don't have a vitreal problem. You don't have a retinal problem. There's no retinal detachment. Come back and see us after a while. That's adequate kind of therapy. Because the alternatives, at least at the present time, are either to remove the vitreous, that can cause some problems, or to try to be like a Starship Trooper with our laser guns and shoot at the individual floaters. And that's also associated with significant problem. Well, the vitrectomy, where we take the vitreous out, that seems to get rid of the problem for those people who are really significantly impaired because of the floaters, because the floaters are causing that contrast sensitivity or causing the stray light and making reading or watching the television difficult and making it difficult to recognize people's faces. Then we have to accept the risk. And there are some risks, because if we remove the vitreous, chances are within 2 years you're going to have a cataract and it's going to have to be operated on. That occurs in more than 50, up to 75% of people who have the vitreous removed. And then there's possibility of infection and all sorts of other problems that can occur in the back of the eye. So we have to decide whether the potential benefit really outweighs the real risk. And as far as shooting the areas, shooting the floaters with a laser gun, well, that's not really been standardized at this point in time. Various energies are used, various lasers are used, typically the neodymium YAG laser, but shooting those laser beams inside the eye can cause some kind of problem. And you can miss too, and you can end up with retinal holes or retinal hemorrhages or swelling of the retina or cystoid macular edema. So the stories that you read about how great the treatment is if you just look in the internet, that's not exactly what reality is. What's the best thing you can do? The best thing you can do is protect your eyes. So if you're involved in some sort of athletic activity, wear an appropriate eye protector for that particular activity. Medicines available? There aren't any. There are no over-the-counter medicines, there are no prescription medicines, and you see a lot of drugs advertised on the internet. None of them work. It's been, the pharmaceutical industry has been trying for the past several decades to come up with some kind of a medicine, and with all of the research into the area, still have not been able to improve the situation. So we have to accept it, at least at the present time, and have to understand what causes it and know that it doesn't foretell some sort of a disaster that's waiting in the wings. So that's basically the story of floaters and flashes. And sooner or later you're going to experience the floaters, and for the overwhelming majority of people it's best simply to ignore them. But when they suddenly appear, they change in size or number, or if you're experiencing any other kind of eye symptoms, Or if you suffered some sort of eye injury or eye trauma, then you ought to check with your eye doctor because it might be a retinal detachment. It might be something more serious than you suspect. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, maybe consider subscribing so you'll be updated as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.